Carpenter. I'd like to thank you for taking the time to join me on this week's video. Well, guess what? We're here. We're at part 4 of our 4-part series on radiculopathy, and today's the conclusion of the entire program, and I'm going to summarize all of the concepts into one final lesson here in this part 4 session. And I want to say that this has been the most interesting and most rewarding series of discussions I think that we've had in the history of this blog discussion series. And the reason is because I think it has to do with the large number of doctors who are involved with examining injured workers who have spinal injuries. And so the topic of radiculopathy is something that's of great concern to a great number of doctors. And so for that reason, I received so much feedback and so many comments about radiculopathy, and the feedback that I received was so rewarding and so fabulous. So I want to thank all of you for participating in this series, and I want you to know that I have even more fascinating and more compelling topics in our upcoming series. So make sure to tune in to those, and make sure to provide me also with your feedback. Your feedback is critical to the success of these programs, and really it's your feedback that provides the material for the ongoing discussions that I'm hosting. Many of you think that I'm the sole author of these discussions, and I'm not. I'm the sole presenter, at least at this point in our evolution, but I'm not the sole author of these programs. In fact, I rely heavily on your experiences, your input, your feedback, your comments for the construction of these ongoing programs. So feel free to provide me with any comments or suggestions or insights or ideas that you may have. We rely on those. And it's your comments and suggestions that allow all of us to benefit from all of our collective knowledge and experiences. And in this way, we create a mastermind group wherein we can all benefit from each other. So stay tuned for even more fascinating topics over the next several weeks and months. Now, in today's discussion, I want to conclude our 4-part series on radiculopathy. And so far, let's just summarize where we've come with this program. We talked in session 1 about the nature of true objective findings. The nature of true objective findings. And that program in and of itself was such an eye-opener for doctors. I received so much feedback about that one program, and doctors were telling me things like, wow, I finally get it. And wow, that makes so much sense. And wow, I felt like I always knew that, but I couldn't actually put it into words. And that particular blog was the introduction to the recurring theme that we then carried into part 2 of the program on the sensory, motor, and reflex examinations. That was part 2. Then in part 3 we talked about the nerve root stretch tests, and I provided material for you on nerve root stretch tests for both the cervical spine and the lumbar spine. So that actually was a complete course on nerve root stretch tests. I think in that program we talked about over 10 different nerve root stretch tests, 6 for the lumbar spine, and at least 4, maybe even 5 for the cervical spine. So that was a complete course. And in today's program is entitled The Consistency and Inconsistency Findings in Radiculopathy. And I want to tie together many of the concepts and ideas that we've talked about already that provided us our foundation for today's discussion. I want to tie in and summarize all of those topics with today's discussion. And just to give you a heads up as to where we're going, I want you to just sort of imagine that you're a disinterested observer at a qualified medical evaluation, and you know a little bit about the history of the examinee, and that is that the examinee has been diagnosed with L5 radiculopathy. Now, let's say that you're a disinterested person attending the examination. Now, when you think to yourself in your mind, L5 radiculopathy, the examinee has L5 radiculopathy, what kind of a mental image picture do you get when you visualize an examinee who's purported to have L5 radiculopathy? Let me ask you, what kind of an image does this conjure up in your mind when you picture this type of an examinee? And this is an important exercise that you can use anytime you do a permanent impairment evaluation, and really anytime that you review the AMA guides. It's interesting because the AMA guides and the authors of the AMA guides describe many conditions in each of the chapters of the AMA guides. And it's useful to think to yourself, what was the intent of the authors of the AMA guides when they provided for permanent impairment for X condition, for Y condition, for Z condition, for L5 radiculopathy, for gait disturbance, for impairment due to hernia and inability to lift heavy objects? What was the intention of the authors? And what type of examinee are the authors describing when they describe a person who has, for example, antalgic gait? When you think of antalgic gait, what kind of a mental image picture does that conjure up in your mind? You expect to see an examinee having trouble walking due to an antalgic gait. The conditions and impairments that are described in the AMA guides are very clear, are very bona fide, are very objective. And many times in our qualified medical evaluations, we see examinees that don't exactly meet or don't exactly rise to the level of the intention of the authors of the AMA guides. So always ask yourself, what kind of an examinee would I expect to see when you already know in advance what is the condition that they're presenting with? And today I want to talk to you solely about how you would expect your examinee to present if they've been diagnosed with radiculopathy. And today we'll isolate and limit our discussion to examinees who've been diagnosed with L5 radiculopathy. Okay, so today's workshop is entitled The Consistency and Inconsistency Findings in Radiculopathy. Now you're going to need your AMA guides for this discussion. And so I'll give you a minute to go ahead and get your AMA guides. And it's important that you do get your AMA guides because I'm going to be referring to some specific charts and tables within the AMA guides. And you're going to want to lay your own eyes, on these charts and tables so that we're on the same page and that we're looking at the same material and that we're together as we go through this discussion and as we go through the philosophy of the consistency and inconsistency findings in radiculopathy. So go ahead and give you a minute to get your AMA guides, and you may also want a piece of scratch paper because I'm going to give you some valuable notes that you can use on your very next evaluation. So go ahead and get those materials, and look forward to being back with you here in just a couple moments as we conclude our 4-part series on radiculopathy with today's discussion on the consistency and inconsistency findings in L5 radiculopathy. Back with you now, and I have my AMA guides with me. I hope you have your AMA guides with you. I really encourage you to get your AMA guides because I want you to look at some of these charts and tables as we go through this material. I also have another reference that I'm going to be extracting some quotes from, and this is a study entitled Electrodiagnosis in Lumbar Radiculopathy, and this is a 2013 study published in the journal Physical Medicine Rehabilitation Clinics of North America. So you don't have this document, but if you'd like to have this document, feel free to send me an email at admin@easyqmeceu.com, and I'd be happy to forward this document to you. It's a fascinating document that gives great insight into many of the issues related to the lumbar spine nerve roots and definitively establishing a diagnosis either for or against lumbar radiculopathy. So I'll extract a couple of quotes from this document as we go. For now, I want to draw your attention to a couple charts and tables in the AMA guides as we focus our discussion here on consistency and inconsistency findings in radiculopathy. And we're going to talk specifically in today's discussion about L5 radiculopathy. Now, all of the ideas, concepts, and topics that we discussed today regarding L5 would certainly apply to radiculopathy of L4, of S1, and also of the cervical spine radiculopathies. But we're going to use L5 for illustration purposes to illustrate today's concepts and principles. Okay? So I want to draw your attention first of all to table 15.2 on page 376 of the AMA guides. Now we're talking here about L5 radiculopathy. Let me ask you, before we even go to this chart, let me ask you, if you have an examinee with L5 radiculopathy, let's say you know you have a bona fide examinee who has been diagnosed with L5 radiculopathy. This is a bona fide case of L5 radiculopathy. Maybe this is someone in your family, someone that you know closely that has no secondary incentive for purporting a diagnosis of L5 radiculopathy. Or maybe this is someone in your clinical practice who's seeking treatment for this condition. This is a bona fide case. Okay? Now, if you know you have a bona fide case of L5 radiculopathy, how would you expect that examinee to present during the physical examination? What are some of the findings that you could reasonably expect on physical exam? Let me ask you. What are some findings? Well, as we go through some of the findings, and I know you're familiar with many or most or even all of them, I want to have you turn your attention from identifying single and isolated findings to a perspective wherein you look at the examinee more on a global perspective. In other words, L5 radiculopathy is a widespread and wide-reaching conditions because of the great distribution of the sensory and motor fibers of the L5 nerve root. So it has many, many, many involvements. And typically we narrow our focus down to simply one or more of those involvements. And the AMA guides actually help to perpetuate that as a philosophy, because here in table 15.2, for example, with regards to the L5 nerve root, they advise us that the diagnosis of L5 radiculopathy or involvement of the motor fibers can be ascertained simply through the manual muscle testing of the extensor hallucis longus muscle, the great toe extensor. Well, the extensor hallucis longus muscle is only one of many, many muscles innervated by L5. In fact, some authorities say that the extensor hallucis muscle is not the preferred muscle to test for assessment of the L5 nerve root. So, as an example, the AMA guides have us narrow our focus down to one muscle, whereas we know that the L5 nerve root innervates many muscles. Well, similarly, the L5 nerve root sensory distribution is a wide distribution. And so we're going to talk about assessing sensory function on a global basis versus on a narrow, focused, and isolated basis. So let's go back to our original question. Knowing the broad distribution and the many effects and functions of the L5 nerve root, if you had an examinee with a bona fide diagnosis of L5 radiculopathy, how would you expect that examinee to present? What physical examinations would you reasonably expect to find on exam? Well, let's talk about some of those. And let's talk about some of the wide distributions of the L5 nerve root simply as an illustration of the widespread distribution of all of the spinal nerve roots. Okay? So let me ask you, first of all, if you had an examinee simply with weakness of the extensor hallucis longus muscle, how would you expect that examinee, and how would that weakness of the extensor hallucis longus muscle present on physical exam? What would you expect that examinee, how would you expect that examinee to test on physical exam beyond weakness to manual muscle testing of the extensor hallucis longus muscle? How else would that weakness affect the examinee? Would that affect the examinee's gait? Well, certainly it would affect the examinee's gait. And typically we think of examinees with L5 radiculopathy as having weakness of great toe, all toe, and then also ankle dorsiflexion. What do we call this type of abnormal gait that involves a failure of ankle, great toe, and all toe dorsiflexion? Well, we call that a drop foot, don't we? We associate a drop foot with L5 radiculopathy because the L5 nerve root, as we know, innervates, as the AMA guides say, innervates the great toe extensor. So these people are prone to catching their toe on carpet, on steps, on curbs, on cracks in cement due to lack of dorsiflexion of the great toe. Well, we know that the L5 nerve root innervates the extensor digitorum longus and also the intrinsic toe extensors, the extensor digitorum brevis. So these examinees have trouble, weakness and difficulty in lifting all of their toes, so they catch their toes. We know that the L5 nerve root greatly innervates the tibialis anterior, even though the AMA guides refer to the tibialis anterior. My mistake. Some references refer to the tibialis anterior as being largely innervated by the L4 nerve root. For the L4 nerve root, the AMA guides require that we test the quadriceps. So let me retract that statement. So many authorities consider the anterior tibialis to almost be purely innervated by L5 with few fibers of L4. So due to weakness of ankle dorsiflexion, these examinees have difficulty raising their foot through the swing phase of gait, and we call this a drop foot. So you're familiar with this. L5 radiculopathy is associated with a gait disturbance known as a drop foot. Okay? So if you have an examinee with a bona fide L5 radiculopathy, could you reasonably expect that examinee to have some form of a gait disturbance, some form of a drop foot? Would they describe this on their activities of daily living? See, what I'm giving you here is I'm giving you some ideas as to how to look at the examinee globally and how to look at the global impact of an L5 radiculopathy on their physical function, both in the physical examination with you and then also in their activities of daily living. So when it comes time to do an activities of daily living assessment, would you expect this examinee to describe difficulty in walking, You would, wouldn't you? They would tell you things like, I catch my toe. They would tell you things like, I get tired with walking. I have to lift my knee high in order for my foot to clear the ground. You would be able to observe this yourself in your observation of the examinee, at least as they walk around the office, and also in your observation of gait in your formal gait analysis. And with the lumbar radiculopathies, you should include a formal gait analysis in each of your physical examination procedures. Okay? So with an examinee with L5 radiculopathy, you would expect them to have some sort of a gait disturbance, perhaps a bona fide drop foot. Now, if you have an examinee who presents with no gait disturbance, what does that tell you about the function of the L5 nerve root? See, gait is a true objective test. Gait is one of the few truly objective tests that we have. So let's talk about gait for just a minute. Imagine if you have an examinee sitting in your waiting room and you motion and call for the examinee to follow you back to the examination room. Now, if the examinee gets up out of the chair, stands, follows all of your instructions exactly, and walks back to the examination room with you completely normally with no gait disturbance, what does that tell you about the function of their L5 nerve root, of their peripheral nervous system, of their central nervous system? If the examinee gets out of the chair, follows all of your instructions exactly, that tells you that their sensorium and their mental status is intact. If the examinee walks completely normally without any disturbance of gait, that tells you that their motor system is completely intact. If the motor system is completely intact, then the sensory system is completely intact. So therefore, in the presence of normal gait is a true objective findings. That tells you that the function of their entire nervous system is intact. So if you have an examinee with diagnosis of L5 radiculopathy with normal gait, what does that tell you? That tells you that the sensory and motor function of at least the L5 nerve root is completely intact, despite subjective complaints of pain that seem to be in the distribution of the L5 dermatome. Okay? How else could L5 affect gait? Or let me ask you this. Is there any other impact of L5 on gait? Well, let's talk about some of the other muscles that are innervated by L5. Let's go up into the hip area. Up in the hip area, we have several muscles that are innervated largely by L5, such as the gluteus muscles, plural muscles. The gluteus minimus and the gluteus medius are largely innervated by L5 through the inferior gluteal nerve, which is L5 and S1. Primarily, the gluteus maximus is largely innervated by L5 through now the inferior gluteal nerve. That's L5, S1, and a little slip from S2. So if an examinee had a bona fide L5 radiculopathy, how could that radiculopathy and how could the weakness of those gluteus muscles manifest as the examinee goes through the gait cycle? How could that weakness manifest? Okay? Well, we know that weakness of the gluteus medius muscle, which is largely innervated by L5, weakness of the gluteus medius muscle on this side during the stance phase of gait causes a drop of the pelvis on the contralateral side. It's the job of the gluteus medius muscle to stabilize the pelvis during unilateral weight bearing. Weakness of the gluteus medius muscle on this side causes the pelvis to drop. What do we call that? We call that a Trendelenburg sign. It's due to weakness of the gluteus medius muscle. Would you expect your examinee to have some weakness of the gluteus medius muscle in an L5 radiculopathy? You would. You would expect that to manifest in gait as some form of a Trendelenburg gait, especially as the examinee walks over distance and the gluteus medius muscle fatigues. So that's something that would be evident on the activities of daily living assessment as the examinee tells you about their function of walking. If they tell you that they're able to walk normally in distances without waddling at the hip and having some sort of disturbance of their gait at the hip, and they don't call it a Trendelenburg gait, but they'll say that they have weakness or pain or weakness of their hip with walking, you would know that, and you would translate that to be some form of the Trendelenburg sign. That's due to weakness of the gluteus medius muscle. Now, if you perform a formal gait analysis on the examinee and you find no sign, there's no indication at all of any unleveling of the pelvis during unilateral weight bearing, what does that tell you about the function of the L5 nerve root? It tells you that it's functioning fine. Despite the subjective complaints of pain in what seems to be the distribution of the L5 dermatome, it tells you that the L5 nerve root is functioning properly, and the muscles that are innervated by the L5 nerve root are functioning properly. So in this sense, we can use gait as both consistency and inconsistency findings. An examinee who has a bona fide L5 radiculopathy, we could corroborate that and confirm that by observing a drop foot, by observing a Trendelenburg gait. Okay? What about the gluteus maximus muscle? Gluteus maximus muscle is innervated by the inferior gluteal nerve. It's L5, S1 with a small contribution from S2, but largely L5. And so how does weakness of the gluteus maximus affect gait? Well, the gluteus maximus is either a hip or trunk extensor, depending upon which part of the body is mobile and which part of the body is stabilized. But at the heel strike phase of gait, when the leg is stabilized, the gluteus maximus muscle extends the trunk to keep the center of mass of the trunk over the center of rotation of the femoral head in the acetabulum. In the absence of function of the gluteus maximus muscle to extend the trunk, the examinee takes on a characteristic gait disturbance known as the gluteus maximus lurch. And the gluteus maximus lurch involves the examinee extending their torso back over the center of rotation of the femoral head at heel strike phase of gait. It's a very characteristic disturbance of gait. It's called the gluteus maximus lurch. You can either Google that or pull up some videos on YouTube. I've talked extensively about these different gait disturbances in another of our QME continuing education home study courses entitled Gait Disturbance and Assistive Devices. So weakness of the gluteus maximus muscle causes a characteristic disturbance in gait known as the gluteus maximus lurch. So in the absence of a gluteus maximus lurch, what does that tell you about the function of the inferior gluteal nerve? What does it tell you about the function of the L5 nerve root? It tells you that the nerve root is functioning fine despite the examinee's complaints of pain. So what I'm giving you here is I'm giving you several different perspectives with which to look at the examinee so that you obtain a global view of their condition versus an isolated or singular view based on simply one or another physical examination finding. Okay? How else would you expect an examinee with an L5 radiculopathy to present? What else? how would they be able to perform in their activities of daily living? They would mostly report difficulties in activities of daily living involving standing, walking, functions of the foot, functions of the hip, okay? So their descriptions of limitations on activities of daily living should be consistent with the known distribution of the L5 nerve root. And let's just talk about some of those muscles innervated by the L5 nerve root. So down in the foot, as we talked about, L5 innervates the extensor hallucis longus, the great toe extensor, both the extensor digitorum longus and also the extensor digitorum brevis. The extensor digitorum brevis is wholly an intrinsic foot muscle. The extensor digitorum longus, of course, originates up on the tibia, so that's an extrinsic foot muscle. So involves all of the toe extensors, extensor hallucis longus, extensor digitorum longus, and extensor digitorum brevis. These people have difficulty moving their ankle and toe, and their activities of daily living would be consistent with that. The L5 nerve root also innervates the tibialis anterior, also innervates the tibialis posterior. Now we know the tibialis anterior is an ankle dorsiflexor. What about the tibialis posterior? Tibialis posterior. Well, the tibialis posterior is a weak ankle plantar flexor, but it's a strong ankle inverter. Strong ankle inverter. It produces the motion of ankle inversion. So if there was weakness of the tibialis posterior and we had weakness of ankle inversion, how would the examinee present? This is fascinating. We need to look at our examinees globally rather than looking at them isolatedly, if that's even a word, isolatedly through singular exam findings. We need to look at the entire constellation of the clinical syndrome. So if there was weakness of the tibialis posterior, how would the examinee present? The examinee would present with eversion of the ankle due to the unopposed action of the everter muscles. See, the action of the everters is generally opposed and balanced by the inverter muscles to maintain the foot in neutral position. Well, with weakness of ankle inverters, the tibialis posterior, the ankle everters are unopposed. So this person would stand there in front of you with eversion at the ankle. They would have basically flat foot. They would have a valgus deformity from the tibia down into the ankle and foot. They would have a valgus deformity due to weakness of the tibialis posterior. How would that affect their activities of daily living? How would that affect their gait? You would observe this as a gait disturbance with increased pronation and inversion at the foot. You see how these muscles impact the function of these muscles, or the loss of function of these muscles impact the examinee throughout the activities of daily living. If you examine your injured worker and you find an absence of these weaknesses or an absence of these impacts on activities of daily living, what does that tell you about the function of the L5 nerve root? It tells you that it's functioning completely normally. Okay? What other muscles? We talked about the gluteus maximus, the gluteus medius, the gluteus minimus. How about the tensor fascia lata? Tensor fascia lata, also innervated like the gluteus medius and the gluteus minimus, also innervated by the superior gluteal nerve, largely L5 with a portion also of S1. So if you had weakness of the tensor fascia lata, the examinee would have weakness of resisted hip abduction because of the action of the tensor fascia lata at the hip. Also, they'd have difficulty stabilizing the knee due to inability to contract and shorten the iliotibial band, which then goes down and crosses the knee. So this examinee is likely going to report problems at the knee, particularly during the stance phase of gait due to lack of stabilization of the knee. Okay? So this is a way for you to look at the examinee by stepping back and looking at the forest rather than looking at the trees. So the general principle is, when you have a diagnosis of radiculopathy, you want to take a look at all the muscles that are innervated by that particular nerve root, and guess what? Assess them all. Assess each and every one of those muscles, both in physical exam and for the impact of weakness of those muscles on activities of daily living. And these findings should all be consistent. Any discrepancy between these findings would lead you to believe that there are some inconsistency findings that would require you to investigate a little bit deeper. Okay, a couple other things. Now, the L5, the AMA guides describe the reflex associated with the L5 nerve root as the hamstring reflex, specifically the medial hamstring reflex. Now, I found that many doctors don't test the hamstring reflexes because they're sometimes difficult to elicit. Well, the best way to elicit the hamstring reflexes, and I say reflexes because we have both medial and lateral hamstring reflexes, the best way to elicit those reflexes is with the examinee prone. With the examinee prone, with a slight flexion to the knee, approximately 30 to 45 degrees flexion of the knee, and then by placing your thumb over either the medial hamstring tendon or the lateral hamstring tendon, you strike your thumb versus striking the tendon itself, and you should get a brisk reflex. Now, both the medial and lateral hamstring reflexes are considered to be, at least by the AMA guides, well, they describe only the medial hamstring reflexes, are considered to be L5 reflexes. Now, some textbooks describe both of them as S1 reflexes. So, all of this neurology is not precise and is not clear-cut. But the AMA guides consider the hamstring reflexes to be mediated by the L5 nerve root. So, it's interesting, though, the medial and lateral hamstring reflexes have the clinical distinction of both being L5 reflexes. However, with regards to the medial hamstring reflex, the L5 fibers from the L5 nerve root travel in the tibial nerve. Whereas for the lateral hamstring reflexes, when we say the lateral hamstring reflexes, we're talking about the short head of the biceps femoris, the most lateral of the lateral hamstring tendons. We have the long head of the biceps femoris and the short head of the biceps femoris. Short head of the biceps femoris is the most lateral. Okay? Long head of the biceps femoris is also innervated by L5 and also travels in the tibial nerve. But the short head of the biceps, the most lateral tendon, the lateral hamstring reflex, is conveyed in the common peroneal nerve. So this is not as important for the assessment of radiculopathy, but for the assessment of peripheral nerve injuries, such as injury to either the tibial nerve or the common peroneal nerve, we can use these two reflexes to distinguish between injury between those two nerves. So I suggest that you assess both the medial and the lateral hamstring reflexes. Now, let's say that we do just what the AMA guides tell us to do when we assess the medial hamstring reflexes, and we obtain a brisk reflex in an examinee with a diagnosis of L5 radiculopathy. Now let's go back to our original question. How would you expect an examinee with L5 radiculopathy to present with regards to the reflexes? We know these radiculopathy syndromes involve injury to the nerve roots, the lumbar spine nerve roots. In these cases, these are lower motor neurons. Lower motor neurons. And so injury to lower motor neurons, we know, gives us hypoactive or diminished activity of the reflexes. They give us reduced reflexes. So you would reasonably expect an examinee who has a drop foot, who has a gluteus maximus lurch, who has a Trendelenburg gait, who has pain in the distribution of the L5 nerve root, you would expect them to have hypoactive reflexes. Now, when the examinee produces brisk and symmetric reflexes bilaterally, what does that tell you about the function of the L5 nerve root? Despite subjective complaints of pain, despite what appears to be a gait disturbance, what does it tell you? This is why I love reflexes. Reflexes are completely objective tests. So in the presence of normal reflexes, you know that the sensory fibers of L5 are functioning properly. You know that the L5 level of the spinal cord, where the sensory and motor synapses take place, you know that this part of the spinal cord is functioning properly and is not damaged. You know that the efferent motor fibers that travel in the L5 nerve root are functioning completely properly, completely normally. You know that the effector organ, which in this case is the hamstring muscles, the end effector organs, are functioning properly. So in the presence of normal reflexes, normal, brisk, and symmetric reflexes, we know that many structures are functioning properly. It's a completely objective test. Despite whatever subjectivity the examinee may give you, we know that objectively, the L5 nerve root is functioning completely normally. So I'm sharing with you several different ways, and there are more, and this is not going to be an exhaustive discussion of this topic, but I'm giving you several different ways of looking at the examinee globally versus looking at any one single isolated finding, and therefore concluding, number one, of a diagnosis, or number two, of permanent impairment related to radiculopathy. It's my opinion and it's my experience that lumbar spine radiculopathy is way overrated as a permanent impairment and does not actually exist in many of those cases wherein permanent impairment is provided for lumbar radiculopathy. More commonly, the examinee qualifies for non-verifiable radiculopathy. So what's the difference between bona fide radiculopathy and non-verifiable radiculopathy? Well, with non-verifiable radiculopathy, we have complaints of pain that are consistent with the L5 nerve root distribution, consistent with the L5 dermatome, but without sufficient clinical findings to substantiate that as a bona fide diagnosis or as a bona fide condition. And I just want to leave you with an important quote from this study that I was referring to a little bit earlier. And again, the title of this study is Electrodiagnosis of Lumbar Radiculopathy. And the whole theme of this study is that definitively diagnosing lumbar radiculopathy is difficult. Even through our physical examination, it's difficult. Even through the use of MRI imaging studies, it's difficult. Even through the use of electrodiagnostic studies, that even in and of itself is not definitive. Positive findings on electrodiagnostic studies are not definitive for radiculopathy. So the theme of today's discussion is that our physical examination is our best bet at arriving at a true diagnosis of radiculopathy. So your physical examination should consider the examinee globally rather than focusing on just a few or even one isolated test. But let me Let me read this quote to you to solidify the theme of our discussion, and then we'll close this series. This is in the introduction on page 1, and I have it highlighted here at the bottom. This is a study from the University of Washington, published in Physical Medicine and Rehabilitation Clinics of North America. So they say that it is not always easy to diagnose lumbar radiculopathy. We know that. We know that. It's not. But the purpose of this entire course has been to make the diagnosis of lumbar radiculopathy easier by helping us to focus on the true objective findings associated with radiculopathy. They say that there are many different medical conditions that cause low back and lower extremity pain. There's many conditions unrelated to the lumbar spine nerve roots. So an examinee can have complaints of lower back and leg pain due to another condition that's not radiculopathy at all. Or they say some patients may have more than one disorder. They may have multiple conditions that result in the constellation of symptoms that include lower back and lower extremity pain, and it's not related to the lumbar spine nerve roots or injury there at all. So there's a couple of reasons why it's difficult. There's many different conditions that cause lower back pain, or patients can have more than one condition. Also, and we find this all the time in workers' compensation, they say some patients are vague historians without a clear recall of their symptoms. And isn't that consistent with your own experience? Don't you find that examinees, and this is no fault of their own, examinees are simply lay people, they're not medical professionals, so examinees themselves are generally vague historians. They don't come to us and tell us that they have pain in the distribution of L5, or they don't say, I have pain on my lateral shin and to the dorsal medial aspect of the top of my foot, top and medial aspect of my foot. They don't tell us straight out in clear-cut fashion these descriptions of their pain. They're vague historians. They'll say things like, it hurts in my leg. I'm not sure where it hurts, but it throbs, and all this stuff that's vague. It's our job as evaluators to pull out the clarity from their vague descriptions. They say sometimes the clinical picture is confounded by issues regarding compensation or blame. Compensation or blame. Issues related to compensation and blame can confound the clinical picture. Isn't that fascinating? And we've talked about this on other blogs, and I want to let you know that I have an upcoming series. It's going to be a 4-part series, and it starts next month. It's on deception, symptom magnification, and malingering. And in that program, we're going to explore in great depth how the clinical picture can become confounded by issues related to blame or compensation. Isn't that amazing? So my plea to you is to not be confounded. Don't be confounded. Be clear. Don't let issues of blame and compensation confound the clinical picture. Your clinical picture should be based on the true objective findings. That's the theme of this entire program. We look at the examinee globally, and we look at them for the presence of true objective findings. In the absence of true objective findings, the examinee does not qualify for radiculopathy. They qualify for non-verifiable radiculopathy at most. And just a couple more statements about the subjective nature of the radiculopathy exam. They say that the physical examination relies on the patient's cooperation and may be difficult to interpret. Again, we need to remove the subjectivity and focus on what's truly objective. And I think that drives that point home sufficiently here. So let's review the theme of this entire program. The theme of this entire program is that we are presented with examinees who bring to the impairment evaluation a lot of subjectivity. It's our job as evaluators, as expert and competent evaluators, to sift through the subjectivity and arrive at a diagnosis and a permanent impairment rating that's truly objective, as truly accurate, and it's based upon true objective findings. Now, this applies not only to our evaluation of examinees with radiculopathy, but it applies to our philosophy of our entire physical examination procedure. And that is, true objective findings involve some form of evasive action and some form of withdrawal from the pain. Absent evasive action, physical examination findings qualify as subjective findings only. And our job as medical evaluators is to identify and accurately report and provide for permanent impairment ratings based simply on the true objective findings of the case. And so in that way, always ask yourself, what's truly objective here? That is a question that will serve you time and time again over the entirety of the remainder of your career. Always ask yourself, what's truly objective here? So doctors, I hope this program has been enlightening and informative for you. I hope you learned a lot of things. And I believe that these are some techniques and some philosophies that you can implement into your very next evaluation, whether that involves an evaluation of the spine or any other body part. So that concludes our 4-part series on radiculopathy. I look forward to being with you next month for a series on symptom magnification and malingering, and then also for additional discussions and additional series on into the future. So for now, this is Dr. Perry Carpenter saying it's been my pleasure to be with you. I look forward to being with you on future programs. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.